Okay, let's jump right into the third and final part of our explainer series. We've spent a lot of time dissecting front door stratification and bedside testing, right? But how do we actually safely get the dizzy patient out the door? Today, we're diving deep into the essential structural disciplines of referrals and medical legal documentation. These are absolutely crucial final steps for closing the disposition loop in the emergency department.
As we wrap up this Australian Dizziness Clinic series, we're shifting our focus away from that initial clinical assessment and looking at exactly what happens next. You can think of today's framework as the two shields. These shields are designed to protect two very specific people: the patient as they leave the hospital and, well, you, the clinician actually signing that discharge paperwork.
Now here is our core mantra for today. Match the pathway to the differential, not to the loudest symptom. A disposition decision doesn't just magically end when the patient walks out the automatic doors. It only truly ends when the right patient reaches the right clinician at the right urgency. It's about building a bridge, not just pointing to a doorway.
So, here's our roadmap for today. We'll be covering closing the loop, outpatient referrals, medical legal risk, the discharge summary, and our final takeaways.
Section 1. Closing the disposition loop.
The absolutely critical point to understand here is that the patient leaving your department is not the finish line. It's just a handoff to the outpatient network. Safe disposition is a structural discipline, you know? You stratify, you decide, you document, and you refer. If your clinical reasoning isn't clearly visible in the chart, and if that patient doesn't know exactly who they are seeing next, well, that loop is still dangerously open.
Section 2. Outpatient referral pathways.
This is where we structurally map out that first shield. We are moving entirely away from giving a patient a generic, "Hey, just follow up with your doctor," laundry list. Instead, we're replacing that with a highly targeted routing rule. Suspected central pathology, or a TIA, that needs neurology in under 24 hours. A really complex refractory case, they need a vestibular physician in 1 to 2 weeks. You've got to map the patient's specific presentation directly to the expert equipped to handle it.
Tailoring the pathway to the working diagnosis guarantees early, targeted specialist involvement. For example, if it's BPPV, get them straight to vestibular physiotherapy. If it's vestibular neuritis, they actually need primary care plus physiotherapy to help drive central compensation. By accurately routing these folks, we drastically reduce repeat ED visits, and honestly, we spare the patient months of unnecessary, miserable dizziness.
Section 3. Medical legal risk and stroke.
Okay, we've all seen it, usually at 3 a.m. The dreaded benign vertigo not yet diagnosed trap. You absolutely must avoid this. It is a massive red flag, especially in patients over 60 with vascular risks. You cannot leave the diagnosis vague. You've got to either commit to a clear benign diagnosis with the exam findings to back it up, or you must broaden the workup. Ambiguity here isn't just confusing, it's a huge liability.
Here is a major reality check for us. Missed posterior circulation stroke is the single most common successful claim against ED clinicians in this presentation group. And what drives it? Almost entirely, it's driven by an incomplete exam in a high-risk patient. You know the profile. An older adult with vascular factors, quickly slapped with a vague vestibular neuritis label, who later returns with an evolving cerebellar infarct.
So what's the big takeaway here? In this high-risk population, structured testing and a remarkably low threshold for MRI, DWI are not optional. They are the standard of care. If the HINTS exam is equivocal, or maybe it simply wasn't performed because the patient was too nauseous to tolerate it, do not guess. Just get the imaging.
Section 4. The structured discharge summary.
This highlights a really sharp, unforgiving reality in medicine. If you didn't write it down, it legally didn't happen. Documenting what you considered, and specifically the negative findings you established to rule out red flags, is just as critical as documenting what you actually found.
To build a truly watertight discharge summary, you need a very specific triad. Number 1, findings actually checked and documented. Number 2, your clinical reasoning explicitly stated. And number 3, follow-up actually booked, not just vaguely promised. This proves to anyone reading the chart that your safe disposition wasn't just a hunch, it was a structural discipline. To achieve that level of defensibility, here is your minimum data set. You need history and vascular risks, the full HINTS Plus, and gait results. And hey, quick side note, missing the gait exam is a notoriously huge pitfall, so don't skip it. You also need your differential diagnosis, the testing performed, and your written safety net advice. Explicitly charting exactly why you ruled out serious pathology makes your clinical reasoning beautifully transparent. And when you're giving that safety net advice, it needs to be specific. Give strict return precautions for things like new focal neurology, and always include driving restrictions. Oh, and here is a massive clinical pearl. Advise early vestibular rehabilitation. Do not, under any circumstances, recommend bed rest for vestibular neuritis or BPPV. It actively delays central compensation and worsens their outcomes. Setting clear boundaries empowers your patient.
Section 5. Final takeaways.
Over the course of this explainer series, we've moved all the way from front door stratification right through to the outpatient network. Going forward, always remember these 3 pillars. Referral pathways are dictated by differential and urgency. Missed posterior fossa stroke is, without a doubt, your biggest medico-legal blind spot. And finally, a structured, comprehensive discharge summary is your absolute strongest defense.
Thank you so much for joining me for this complete explainer series. To dive into more clinical resources or to access materials for both clinicians and patients regarding dizziness and imbalance, make sure to visit AustralianDizzinessClinics.com. Please don't forget to subscribe and leave a rating. I'll leave you with this final thought. The next time a dizzy patient is ready to leave your care, take a hard look at the chart and ask yourself, is the loop just open or is it truly safely closed? See you next time.